so that we have an idea what we are going to do, and then we will I will hand over the mic to Dr. Ramakrishnan, who is our director for critical care unit, also a sleep intensive, sleep specialist. And after that, we are open to question and answers from everyone. So I'm handing over the mic or the dashboard to Vijaya, who will walk us through the sleep assessment. Over to Vijaya.
Okay. I hope you are
Hello, can we?
Vijaya. Yeah, you're on mute. Vijaya.
Yes, now?
Are you able to hear us now?
Yes. Yes.
I think because mine is connected.
Yeah, yours is connected, so you don't go on mute. Okay, so we just wanted to start off and walk you through the sleep risk assessment that's built into the health check summary as of today. So all of our um, health check summary, you can see there is different sections. Under systemic review, we've created a section called sleep assessment. Based on who you feel needs this assessment to assess the risk for sleep apnea, you can administer this questionnaire. This is basically the stop bank questionnaire, and you can you can implement this for any of your health check guests that you think actually need this. You can see there's a set of different questions here. I'm just going to go ahead and select some of these options. Do you snore loudly? Do you often feel tired? Anyone observed you stop breathing during your sleep? Have you been treated for high blood pressure? Yes. Then there is a question on BMI, age, neck circumference, and a gender. Once you fill these questions, and I think the way we have set it up is some of these questions, for example, your height and weight, you would enter in your physical examination. So from that, the BMI is automatically calculated. When the guest is going through their registration, their gender and age is already determined at the back end. So whatever information is there in the system or captured earlier is automatically fetched over here. For example, if you have said in the present known illness that they are being treated for high blood pressure, then this option of yes gets auto-populated. So the advantage is that out of these 8 questions, you really have about just 3 or 4 questions that you will need to fill up. The remaining, so for example, the snore, feeling tired, observed anyone observing you stop breathing, and neck circumference, also if you're measuring. So basically, it's just these first 3-4 questions that you need to answer. Rest all is actually auto-fetched from the medical history. Once you've entered all of this, all that you need to do is do a calculate. And based on the algorithm, it will determine, or it will at least determine what is your risk, whether it's low risk or high risk. And based on that, the related recommendation is also auto-populated. Right? And the way we are doing it now is in each of the units, we are also putting up a QR code at the relevant points. So if you feel that any of your guests need this, either you can do this as a question and answer with them while you're doing the medical history, or you can ask them to just scan the QR code and fill up this short questionnaire, and all of this information then flows into the medical history for you to review. That's the way we've set up the sleep assessment as of today. Anything else you'd like to add? So I can maybe show another profile where we this and
Srividya, do you want me to comment now or after I do my talk?
We would take the comments after the talk, Ramki. If you are ready, we can go ahead with your talk and then come back to this assessment, and you can give us your opinion on that also.
Sure.
Yeah. So Dr. Ramakrishnan is not somebody who is new to us, but I chose him as my pilot because I know about his passion for various sleep disorders. And I requested Dr. Ramakrishnan that we do not talk about, obstructive sleep apnea at the minimum, because that is something which is being at museum. So over to Dr. Ramakrishnan. Thank you very much, Dr. Ramakrishnan, for taking our time spending this 20 minutes. We are looking forward to interaction.
Yeah, it's my pleasure. I'm just going to try and open my presentation. Just give me 1 second. Can I share the screen now, or is somebody else sharing?
You can share, please.
Is it showing up?
Yes,
Yes.
we have it.
Okay. All right. Great. Thank you for the invitation, Srividya, and welcome to heading the Pro Health. And I'm so glad that you picked this as one of your first initiatives, if I may say so. And that puts the extra pressure on me to not make this a sleepy talk, but more an awakening talk. So I think there's been a lot of focus in Pro Health, and I know Chairman always speaks about non-communicable diseases. And we all know that other than the past 2 to 3 years when we were talking about nothing but COVID, we all know that the World Health Organization clearly says that more deaths are happening from non-communicable diseases than communicable diseases. And when we think of non-communicable diseases, we often think about obesity, hypertension, diabetes, heart disease, hyperlipidemia or dyslipidemia, if I may say, and cancer. But we forget that there's something else that's probably a forgotten NCD, and those are the sleep disorders, which are probably more common than all the other NCDs that I just mentioned, and more importantly, can lead to several of those or lead to complications of several of those. Now, interestingly, there is more and more awareness being created in the media about wellness, and we talk about the triad of sleep, diet, and exercise, but clearly there's a lot of information that's available in the print media and the digital media on sleep. Now, there was an editorial published in the Lancet Diabetes and Endocrinology in 2015, very appropriately titled as Dying for a Good Night's Sleep. which talked about the impact of urbanization, noise pollution, and disturbed sleep, and the long working hours, and more importantly, shift work, which can significantly affect the sleep, being associated with an increased risk of type 2 diabetes. And the authors in this editorial clearly mention that clinicians should start exploring these factors which are affecting the metabolic health and possibly are modifiable and work on those. Now, sleep problems are extremely common, and as Dr. Srividya said, obstructive sleep apnea is being more and more talked about, but clearly it is at least as common as asthma and probably not even about 10 to 20% recognized as asthma is. Most sleep disorders can be serious, particularly if it is not treated, and it can lead to several other comorbidities like hypertension, diabetes, heart disease, and stroke. And if diagnosed early, are treatable. More importantly, clearly we should understand that you do not always treat them with medications. Sleep problems are significantly underdiagnosed, and depending on the studies and surveys that you look at, you notice that there are about 90 to 95% of the problems are probably going untreated. I also want to specifically mention that every person with a sleep disorder does not need a sleep study. And if you don't treat the sleep problems, it can be very expensive, both direct and indirect costs from the sleep problem, which affects the productivity. It can lead to accidents, including road traffic accidents and industrial errors, all of which are extremely expensive. Now, this is a profile from our sleep clinic, where, as you can see, a good chunk of our sleep problems are insomnia. It's about 45%. And another 47% are patients with sleep apnea. But we also see patients with circadian rhythm disturbances, restless leg syndromes, nocturnal seizures, sleep seizures, bruxism, and several others, and which we'll talk about a little bit more. We did a study where we looked at 1,000 consecutive patients, and we found that most of our patients were self-referred. They looked at media or found some information and came to us rather than being referred by other physicians for the sleep problem. Which takes us to the question on how much sleep is really good enough and when do we really have a problem? Obviously, the sleep requirement varies with age. As you can see here, a newborn can sleep almost about 14 to 18 hours through the day, and the sleep gradually shrinks, and at about school going age, the child starts sleeping about 10 to 13 hours, some of which may be during the afternoon. And as they advance in school, they almost get to adult sleeping patterns somewhere in their teens and young adult ages, when they roughly need about 7 to 9 hours. But I don't think any child gets that now, considering all the competitive exams and several other commitments that they have. And as adults, most of us would need somewhere around 6 to 8 hours. And older adults or senior citizens also require similar amount of sleep, although some of them may take part of that in the afternoons. That's essential. It's also the quality of sleep that we need to look at. And this is what we call an hypnogram. And as you can see here, in an 8-hour sleep period from 11 p.m. to 7 a.m., you can see that we go through 4 stages of sleep. Stage 1, which is extremely light sleep, which just happens when we start sleeping. Stage 2 is the predominant sleep that we have. Almost about 45 to 50% of our sleep in the night is stage 2. Stage 3 is also referred to as slow wave sleep or deep sleep. And as you can see, it's a lot more dense in the first half of the sleep than in the second half of the sleep. It's about 20 to 25% of our sleep. And lastly, but not the least, the REM sleep or the rapid eye movement sleep, which, as you can see here, happens approximately every 90 to 120 minutes during the sleep. And most of us would experience about 4 or 5 REM cycles during the night. And you can see from the hypnogram that REM sleep is a lot more dense in the second half than in the first half of sleep, and are also much longer in the second half. The only thing that I do want to mention here about REM sleep is During REM sleep, if we have dreams, we remember it. During non-REM sleep, if we have dreams, we do not remember it. That's why the early morning REM sleep, when we may have dreams and wake up with it, we sometimes very clearly remember the entire dream. So when we talk about good quality sleep, we also talk about what we call sleep hygiene, which is essential for getting a good restorative sleep. By restorative sleep, I mean sleeping adequately and waking up feeling fresh, awake, alert, active to work the next day and be productive. If you get that sleep, you probably had a good restorative sleep. Number one is setting a regular sleep schedule. Most of us would sleep somewhere around 9 to 11 p.m. and wake up somewhere around 5 to 7 a.m. And in between this period would sleep about 6 to 8 hours. And it's good to have some kind of a routine, although we may all miss that once in a while, which is okay. Having a relaxing environment when you are sleeping is absolutely important. Not having a very noisy environment, not having too bright, watching television, all those is not recommended when you are in your bedroom and getting ready to sleep. Understanding your sleep pattern, honoring your circadian rhythm. Again, there are some who are very erratic about their sleep very late, wake up very late, the next day sleep early. So that certainly does not help. And not sleeping well for 5 days and trying to catch up over the weekends does not really help. It's almost like starving for 5 days and eating on the other 2 days. Exercising on time in the morning, preferably with some sunlight exposure, is a good sleep hygiene to promote sleep. Disconnecting and kind of relaxing or unwinding is absolutely key. Keep your work aside and make sure that you have some kind of relaxation strategy and unwind before you go to bed. And avoiding alcohol, smoking, caffeine, any of those stimulants is also equally important. Now, what are the common sleep complaints that we see in a sleep clinic? Number one, as I said, is insomnia, those who cannot sleep. These are people who at some stage will definitely see a doctor because they absolutely cannot cope with not sleeping. The second group, which is the excessive daytime sleepiness, are the ones who often do not see a doctor because they are sleepy all the time and assume that they have no problem with their sleep. And in fact, very proudly say, I have no problem with my sleep because I can sleep anytime, all the time, and even when I'm at work. Fragmented sleep is another common problem where they go to bed on time, wake up on time, but in between wake up several times. Circadian rhythm disturbances and parasomnias, which are something abnormal that happens during sleep. I may not go into detail on that, but it's just more like sleepwalking, sleep talking, sleep eating. All those are disorders that are clubbed together as parasomnias. So what happens if somebody doesn't sleep well? The best way to remember that is like if we don't sleep one night and wake up the next morning, we wake up feeling irritable with a headache, eyes are red, cannot focus, and over the course of the day feel extremely fatigued and easily sleepy. So if you multiply this by several times, when people have what we call sleep debt or accumulating a sleep debt, they can develop mood problems, impaired vigilance, unable to focus at work, significant memory problems, fatigue, which can lead to work related accidents and also auto accidents or motor vehicle accidents. Falling asleep on social occasions, which becomes an embarrassment for several of them. And in the long run, as I said, several of these people can develop stress, anxiety, depression. So some of what we call psychosocial problems is what they could develop. Truly, sleep deprivation is a public health problem. It's an epidemic that we are seeing. It's a lifestyle problem that we are seeing. And increased sleepiness has been shown to associate with reduced productivity, which is what the corporates have a huge concern about. Industrial errors, again, can cause many lives, motor vehicle accidents, and disasters. In fact, there are some hypotheses saying that even the Bhopal tragedy and the Exxon tragedy were all probably related to somebody who was sleeping. So we'll move on. That's about insomnia and what happens. And my idea is not to go through every single problem and address how to treat it, but I just wanted to mention so that we know what it is, and I'm happy to take questions at the end. When we talk about excessive sleepiness, the first thing that comes to our mind is obstructive sleep apnea. And I was glad to see that questionnaire that was there. There are several kind of forms or questionnaires that we have, stop bank, several of those that can screen and identify patients with sleep apnea. Basically, these are patients who are snoring at night, some often have dryness of throat, wake up several times in the night because of nocturia, and then, like they're witnessed to have these apneic episodes, or sometimes they may say that they're choking or gasping for air during sleep, and wake up with severe headaches and feeling sleepy and tired throughout the daytime. And that's what you were trying to catch in your questionnaire. And once again, if there are people who are having sleep apnea, they seem to be performing poorly at work or in school. Even children can have sleep apnea, concentration problems, marital problems. We see several people with the spouse snoring who have a problem relating to that, and it can lead to marital disharmony. Can also lead to depression and overall impair the quality of life. And I wanted to specifically bring this up. I know you mentioned about obesity, you mentioned about the neck circumference. More common in men generally somewhere around 40 to 60, but after menopause, women can have similar incidence as men. Other common precipitating factors or risk factors include hypothyroidism, hypertension, diabetes, and anatomical abnormalities. By that, if you can see from this phase, you see that people with retrognathia, mandibular hypoplasia are significantly at higher risk for sleep apnea. And why I asked you whether I should ask a question now is, in Indians, we see a lot of non-obese obstructive sleep apnea relating to the craniofacial structures, relating to maybe central obesity, particularly in men, and therefore going purely by BMI may not be a great idea in our setup. And also, the BMI of the West does not apply to us for categorizing obesity. In fact, now there is a new paper that has come out that BMI may not really be helpful at all in identifying obesity. Some of the medications can worsen sleep apnea. Alcohol, clearly on the nights that patients consume alcohol, their snoring would be worse and it can worsen sleep apnea. Smoking, and there can be a family history. If there is a person with sleep apnea and it's uncontrolled, it can lead to uncontrolled hypertension. So on the reverse, I would say that if you are seeing a patient who has 2 or more medications for hypertension and it is not getting controlled, and if they are snoring, yes, they would benefit from being evaluated for sleep apnea. Same holds good for diabetes, which can be poorly controlled if there is coexisting obstructive sleep apnea that's not treated. Also, patients with obstructive sleep apnea and diabetes are at increased risk of vascular complications. That includes diabetic retinopathy, diabetic kidney disease, and heart disease. Independently, obstructive sleep apnea is a known risk factor for coronary artery disease, heart failure, and arrhythmia. And I repeat, it's an independent risk factor. Even if you don't have hypertension, diabetes, or other risk factors for this heart disease, if you have sleep apnea, you could develop any of these. Same with stroke or cardiovascular disease. And I already mentioned to you about psychosocial problems. Now, I know that there was a mention, and we can discuss this a little later when you have questions. We talked about the screening leading you to opting for a sleep study. I want to focus on the fact that there are different levels of sleep study. Level 1 is a fully attended sleep study that's done in the sleep lab. It's a typical polysomnogram where we are looking at EEG channels, EMG channels of the chin and the leg, thoracic and abdominal breathing efforts, oxygen saturation, nasal airflow, heart rate. All of these parameters are monitored, and there is a technician in lab, and that's the gold standard, which is the level 1. Now, does everybody need it, or is it practical to do it on everyone? Probably not, which is why the study that we are often opting for sleep apnea is what we call a level 3, or a modified portable sleep study, or a cardiorespiratory sleep study, in which we are only looking at airflow, breathing, and oxygen, and nothing else. The reason I'm specifically saying is, if you find this test is positive, yes, you can diagnose sleep apnea. If you find this test is negative, you cannot rule out sleep apnea, because if this person has not slept the entire night wearing this, then obviously there is going to be no apnea, and we wouldn't know that the patient didn't sleep because there are no EEG channels. There's also a level 4, which is predominantly just oximetry, which is not used in adults, but sometimes used in children as a screening before they go in for a diagnosis. This is the classic level 3, which can be done anywhere. It can be done at home, it can be done in a hotel, it can be done in any hospital. And this is what we use for cardiorespiratory sleep study or for sleep apnea. However, in polysomnography, you have to look at the entire gamut of things that I just mentioned about. If you do find sleep apnea, then depending on the severity, which we look at the apnea-hypopnea index, you may decide on continuous positive airway pressure or oral appliances or surgery. But remember, as of today, there are no medications to treat obstructive sleep apnea. I'll move on to fragmented sleep, where people wake up several times. The most common reason for fragmented sleep is other medical problems. Like, for example, somebody with diabetes, which is not well controlled, they may wake up several times in the night because of the hyperglycemia and nocturia. Men with prostate problems for similar reasons can have a disturbed sleep. Nocturnal asthma, chronic lung disease can also fragment sleep. Shift worker syndrome, those who sleep at odd times may find it very difficult to sleep continuously. Heart failure can wake up patients primarily relating to breathlessness. Some medications can lead to fragmented sleep, and the most common one is actually beta blockers. Particularly non-selective beta blockers can affect, and also the statins seem to fragment sleep. Restless leg syndrome is very common, particularly in women during pregnancy, those who are anemic, those who have iron deficiency, those who have diabetes, any kind of chronic pain syndrome, like whether it is back pain or knee pain or any of those can lead to restless leg syndrome. Chronic kidney disease, those who are on dialysis may also experience restless leg. And restless leg is purely a clinical diagnosis. Clearly, the patient would say that they feel something creeping, crawling, they cannot describe it, they just cannot lie still and feel like getting up and walking. And invariably, you first have to look for whether there is any precipitating factors and treat that. If not, there are medications to treat. We'll move on to circadian rhythm disturbance. I already told you that often, like most of us would sleep somewhere around 9 to 11 and wake up somewhere around 5 to 7. That's the typical sleep phase. There are some who sleep late and wake up late. Why do we sleep on time? Because during the daytime, our body, when we exposed to sunlight, secretes vitamin D, and during darkness, the melatonin level goes up, and in the daytime, the melatonin level comes down. Opposite of that is the body temperature, which dips during the nighttime, and this is what is essential to maintain this typical sleep pattern. There are some, as I said, who sleep late and wake up late, and that's called delayed sleep phase disorder, classically in adolescents and college-going students. There is the opposite of this, where people sleep very early and wake up very early, and that classically happens in the elderly, and that's called advanced sleep phase syndrome, where they go to bed at 6 or 7 o'clock, but wake up around 1 or 2 a.m. and cannot sleep after that. There are a lot of things we teach people with circadian rhythm problem. I mean, shift work, I know all of us have worked shift some stage in our life, but people right now working in the BPO or IT industry are working exclusively nights or working odd times like a 1 p.m. to 12 a.m. to 12 midnight kind of a shift and then come home, primarily because they are working for timings of other countries, which means they are chronically jet lagged. And that's what is happening with their problems. And there are a lot of things we can teach them on how to get a conducive environment to sleep better, getting enough rest. More importantly, teaching them how to eat, when to eat appropriately, because their entire thing changes. What is dinner to others is breakfast to them. So all of these things are just requiring counseling that really would help a lot. Parasomnias, I'll just make a mention. As I said, sleepwalking, sleep talking, sleep eating are all common, more in children than in adults. The only thing that we need to keep in mind about parasomnias is sometimes this automatic behavior and all could be related to a temporal lobe seizure. So if we have any concerns on that, if they are bedwetting or if they're confused after the episode, and if you have a concern, doing a sleep EEG would help to identify that. Otherwise, parasomnias can be treated with medications. So I just wanted to close. I'm sure all of us have read this book of 7 Habits of Highly Effective People. So I would say these are 7 habits for a highly effective sleep. 1, keeping a schedule, eating on time, sleeping on time, and exercising on time. Limiting the non-sleeping bedtime. By that I mean don't sit in bed and watch TV, read book, talk, eat, fight. That's not what it's meant for. Bed is meant for sleep and intimacy with your partner and nothing else. So limiting the non-sleeping bedtime would significantly improve sleep. Unplug, unwind at least 30 minutes before sleep. Optimize your sleep environment, which can be a challenge. When there's a couple, one of them might want the air conditioner on, the other one would not want it on. Now there are a lot of smart beds and stuff that are coming to optimize sleep into environments individually. So that is important. Avoiding and limiting any kind of stimulants or anything that would disturb sleep, like alcohol and caffeine, at least about 5 hours before bedtime. Recognizing the inadequate sleep early and seeking help. Now, we describe insomnia as having disturbed sleep unprovoked for at least 2 weeks or more. Because we all may have 1 or 2 nights of not sleeping related to some work or something like that. That wouldn't count as insomnia. It's also important to remember that, as I said, on a rare occasion for a celebration or for a night show or whatever, we may lose some sleep, and that's okay. Once in a while, not having good sleep and accepting it is also an important, effective way to sleep better. So my suggestion in any kind of primary practice is, if you ask 3 questions, you will identify sleep problems. Number 1, how is your sleep at night? How many hours do you sleep? And do you feel fresh in the morning? How is the quality? Are you sleepy during the daytime? That identifies the daytime hypersomnolence. Does anything unusual happen during your sleep? There you can expand on snoring, restless legs, or any of the parasomnias. And if these 3 questions are asked, you will definitely screen and capture any sleep problem. Good night is essential for a good day. So I wish you all a good night, and I'll stop here and I'll take any questions.
Thank you very much to Dr. Ramakrishnan. Very, very crisp, and I think definitely you have raised a lot of questions. Where you said that the BMI is not the only parameter for obesity. Is that what you said?
Yeah, so BMI, particularly in India, we have published along with some other institutions where we have shown that in India there are a lot of non-obese obstructive sleep apneas. So you cannot go by just the BMI to identify or screen for sleep apnea.
Yes. We are open for questions. You can either put it in the chat and I can read it out, or you can unmute yourself also and ask, so that, yeah, but please raise your hand so that we don't have too many people on the chat.
They say that if there are no questions, saying that everything was clear or nothing was clear.
So this is, I wouldn't say this was not clear. Actually, it was very, very clear, and you said good night at the right time. So, so especially because this is a post-lunch session, my one question, as usual, I met was, okay, now when we talk about daytime somnolence, one is the fact that you will not have had a good night's sleep, yes. But there is always that one factor that, you've eaten a big meal, or, you concentrate somewhere that in this narcolepsy. What do you have to say on that?
Your voice was breaking. You said the daytime sleepiness primarily is because if you're not getting a good night's sleep. Okay. What else did you say?
In case that is not the issue, what else can factor into that?
Sure. So, I mean, as I said, I didn't go into deeper, more rarer problems. the most common reason for feeling sleepy in the daytime is not getting enough sleep or not getting good quality sleep. Now, if you have excluded these two, then there are rarer conditions. One is called narcolepsy, and narcolepsy in India is quite rare. I mean, like in the last 20 years, I've seen maybe about 40 narcoleptic patients at best. So it's not very common. But there they have a sense of feeling sleepy. They cannot control sleepiness. Uncontrollable sleepiness is what they have. Additionally, they may have symptoms called cataplexy, where they, like lose control of their body with any kind of emotion, whether they are happy, sad, any of them can lead to collapse, like literally the muscles lose control. It's because of the overlapping of wakefulness with REM sleep is what happens there. And they can also have what is called sleep paralysis, where, like they feel that their body is paralyzed, they cannot move their body, but they know what's going on around them. Okay. And also they could have what is called hypnagogic hallucinations. Hypnagogic is during onset of sleep, they could have some visual hallucinations. Since I mentioned about this is the tetrad of narcolepsy, but all of them will have sleepiness 100%. Okay, but not the other ones are not that common. In fact, some people can develop sleepiness and then develop cataplexy much later on as well. Sleep paralysis sometimes can just be isolated. Just because somebody has sleep paralysis doesn't mean they always have narcolepsy. Even, like not getting adequate sleep, being sleep deprived, sometimes young people can get isolated sleep paralysis. There is a test to do to diagnose narcolepsy. It's called multiple sleep latency test. We do that only if we have excluded other things.
Yes. Thank you. That was quite in detail. We have Rama asking. Rama, you can unmute yourself and ask.
So, do we have daridorexant in India? Number one. Number two, what's your safe prescribing dose for melatonin, which is OTC at a smaller dose, like 3 milligrams, almost max off? And number three, I actually have personal friends, and I'm sure you do too, who tend to take Provigil to wake up and then Ambien to fall asleep, and you just play with the architecture of sleep as needed. My solution is rather simple. Just show up at the place, go with the sun, don't go home, land in that new country with the new time zone and keep moving on till you get exhausted and collapse when the sun is down. And that sort of resets your circadian rhythm, I think. But I do know a lot of people who do both Provigil and Zolpidem alternatingly on an as-needed basis, and or use quite a bit of melatonin. And then the new drug that's out there for 2023 for sleep. Your thoughts on that? Thank you.
Okay. So first question, did you ask lemborexant or did you ask the next one? You need to unmute yourself, Rama.
Daridorexant.
No, it's not available. Lemborexant is available right now, but not other ones. But honestly, you are right. This is like saying that for diabetes, every morning I will take insulin, I'll drop my blood sugar, and every evening I'll consume more sugar. That's not how you treat diabetes. So similarly, how when somebody is sleepy during the daytime, this is not like you go and give them modafinil in the morning and something to help sleep in the night. That doesn't work. You need to identify what the problem is, and we need to treat it appropriately. With regard to melatonin, it's worrisome that the fact that it's over the counter and it's available as gummies, it's available online. There's going to be a lot of abuse with melatonin. It's useful when you are dealing with circadian rhythm problems. It is useful when people do not get enough sunlight or if they are dealing with jet lag. And there is some study on using melatonin for REM behavioral disorders and stuff. But other than these specifics, just to use it as a sleep aid, thinking it's easily available is completely not recommended. And more importantly, if 1 milligram or 3 milligram doesn't work, 30 milligram will not work. So there is no reason for people to be taking 5 and 8 and 10 and 12. It doesn't work.
And I think to follow through the new wonder drug, or rather the old drug, which is touted because of all the interest in the pineal gland and the CIA research or ecstasy, and how that's supposed to, in smaller doses, make you a Superman as well as have lovely dreams and completely restructure sleep architecture and hygiene.
Ecstasy.
And then you are exhausted the whole day, the next whole day. I mean, you have your own answer there, Brahma. And
Yes, you like
I think it is very,
it's an abuse drug, so that's what it is.
I personally feel that then medication, it has always been hygiene, implementing the right sleep hygiene over and over, like diabetics about medication and insulin diet and exercise. We have to include this in our discussion at museum, and probably we'll start making some headway. So we have Anisha, she is our actually she is our how should I call her, think tank. If she is coming up with question, you be prepared with the answer now.
No, no. Thank you, Dr. Srividya. Dr. Ramakrishnan, I have two questions. This is related to the tool that Vijay demonstrated a while ago. So we in ProHealth are using Stop Bank basically to assess the OSA. So my two questions is in the light, like even the ProHealth team conducted one study, which is still not published, but in the diabetics, we conducted a study where we found out OSA was like 91% of the people who had OSA had a neck circumference less than 40 centimeters. And also, like BMI very rightly pointed out, that was our finding also. In this light, how do we go about it? How relevant is Stop Bank in assessing the OSA? And if it is not, then what is the alternative that we can explore? The second one is, okay, I'll go after the first one. You can please take this.
So, like a lot of the things that would matter in the West are different in the, in our population. So I would still say that in the stop bank, the stop is probably quite relevant. All of those, like do you snore? Do you feel tired? Have you been observed to stop breathing? Do you have high blood pressure? I think those four, without any doubt, are good screening for us as well. Okay. From the bank standpoint, the BMI of 35 there is like whatever you call it, super obesity or very obese. So I think we need to look at whatever is the Asian criteria for that and apply that. Okay. Age of 50, yes, it does make a difference. Neck circumference, actually, the earlier studies said 17 inches in men and 16 inches in women. So I think we have gone with the lower one, which is also okay. And in general, men are more like more prone to OSA than women. So I agree that using the stop bank is a reasonable way, but with our kind of volume, I think we are in a position where we can show, if we can add one more question saying that what is your BMI, or rather than saying is your BMI more than 35, and then we might identify that BMI is not at all a proper risk factor for us, and we can publish that. So I think with our large volumes that we see every day across the different Apollo hospitals, we can come up with our own modification of stop bank, if I may say so.
It's very interesting. Thank you so much. Because I work in the research area of the ProHealth, and this is very interesting and one of the things that probably will take up and probably will come back to you for your inputs and how we can go about validating this and taking it at a larger stage.
I'm happy
Second
to share
question.
the studies with you, so you can email me. I'll send you the studies that we have done.
Thank you so much. Thank you. I'll take you up on that. My second question is, though we use stop bank for obstructive sleep apnea, what if we want to assess not very extensively, but as a screening tool, as a sleep as a whole, rather than one condition, that is OSA? What can we use, and like, is there any tool that we can use, like a questionnaire or like any simple assessment that we can use?
So that's why I told you those three questions. Like that is a good one to identify all the sleep problems. That was my last slide, if you remember. So
No. Our problem is not like I saw your slide. So like what I'm looking is to have an objective answer. For example, can I put it into, rather than someone asking, because the questions that you said, there can be multiple answers, right? Is there anything that would objectively identify, even if a physician is not there, if I want to create a questionnaire and give it to a guest that is coming to us, or like, is there
There is something
something
called
like
a
that?
BEARS sleep screening tool. It's called BEARS, BEARS. Okay.
Okay.
That basically looks at B stands for bedtime problems, E is for excessive daytime sleepiness, A is for awakenings during the night, R is the regularity and duration, and S stands for sleep disordered breathing. So, like you can look at that and that will pretty much identify all sleep problems.
Great. Thank you so much.
Thank you. Rama, anything? I think this was anything to wrap up, Ramkrishnan? You want to add anything?
No, I must say that I'm very glad that we now have a tool that we are looking at to identify sleep problems, because even when I have come for my own preventive health checks, I've seen that evolve over the years. About 10 years back, nobody asked me anything about sleep. It was just I used to tell them I sleep well, but it's just, I think definitely it's something good, and we have tremendous scope for a lot of data and research in our pro health. So I think we should work on that on this regularly. And I want to reiterate what you said: sleep apnea is not the only sleep problem. And that questionnaire that we have, the Stop Bank, is predominantly aimed at sleep apnea, which is why it almost tells you what do you want to do next and order a sleep study. Now, when you use the BEARS questionnaire, you're going to identify so many other sleep problems which do not need a sleep study. It may require a consultation. So I think you need to keep that in mind when you are modifying your questions.
Thank you very much, Dr. Ramkrishnan. Really, really appreciate you taking time again. Dr. Udaya, can I have one word from you about what we are doing at Pro Health, and because we are starting the series of webinar, ma'am, can I have a small word from you?
Sorry, Dr. Srividya. Can you repeat it? What did you say?
Can you give us some advice about, because we're just starting the webinar, and about the topics, any suggestion from your side?
Maybe after another one or two meetings. Let's wait for another couple of meetings, Srividya.
Sure. Thank you very much. Dr. Satya? Yeah, CEO.
Sorry, I'm absolutely delighted, and thank you, Dr. Ramakrishnan. Very, very insightful. And I'm, firstly, as you rightly said, we are committed to expanding the definition of preventive health, because it's not just about blood and imaging tests. We've done that for a long time. And sleep is one that's very close to my heart. And so it's very helpful for us to, A, get validation that it is indeed important, and B, also learn that we are only we don't have the perfect answer, so it allows us to keep evolving, right? I think thanks to you and your time for engaging with all of us, and we look forward to continuing to do so, to really raise the bar on how we can get people to sleep better.
Thank you.
Thank you very much. Thank you all. Looking forward to another interesting session. Probably in a month's time, we will send out the announcement at the right time. Thank you very much. Thanks, Ramki.
Thank you.
Thank you.